Dear colleagues, ladies and gentlemen, it's an honor and a pleasure to give a lecture about anatomy, physiology and physics of the vestibular system. Let's start right away. When people talk about vestibular disorders, they often talk about vertigo. Is that correct? Is there nothing else? Let's have a look. In case of an acute unilateral peripheral syndrome, like in a neuritis, then we see very impressive symptoms. For both patients and doctors observe quite alarming things. Such a loss can be of course unilateral and bilateral, but let's first focus on the unilateral loss. So the initial symptoms are then vertigo, nausea and nystagmus. Then central compensation in the brain tries to restore the imbalance between the left and right vestibular system. That process starts already within hours. And there's a critical period, a window of 8 days, in which the brain really wants to start this compensation as fast as possible. So we have to activate the patient because the movement will stimulate this compensation process. In case of a unilateral loss, there is of course a reduction of sensitivity for motion, but the healthy labyrinth still helps to maintain as much functionality as possible. But that will be partly. 2 labyrinths are of course better than 1. A bilateral loss, that is a severe problem, and then we are really dependent on sensory substitution from vision and somatosenses, for example. Of course that will help, but again partly, because it will not restore the function of the labyrinth. We see that with this central compensation there is a recovery in a few weeks to months, so pretty fast. As I told you already, I think there is a bigger problem when you lose 2 labyrinths than 1. That's not a surprise. It's exactly the same as with eyes and ears. Your right eye sees much further to the right than to the left. And your left eye sees much further to the left than to the right. And thanks to these two eyes, you have a broad field of vision. If you lose one eye, then you have a problem, of course, and you have to take care. But if you lose 2 eyes, you're blind, and that's a disaster. For hearing, very similar. With your right ear, you hear much better sounds that coming from the right than from the left. And with your left ear, you hear much better sounds and tones that coming from the left than from the right. So thanks to the 2 ears, you have a broad field of sensitivity for tones and sounds from everywhere. If you lose 1 ear, then you have to reposition yourself towards the sound to cope with that. It's possible, and many people can cope with that pretty well. If you lose 2 ears, you're deaf. That's a real disaster, and then you depend on other solutions like hearing aids or cochlear implants, even in severe loss. Now for the labyrinths, it's exactly the same. Your right labyrinth is more sensitive for movements to the right, and your left labyrinth is more sensitive than movements to the left. So they feel a little bit the opposite movements, but not as good as the real labyrinth on the right and the left labyrinth on the left. So if you lose 1 labyrinth, you get a direction preponderance. You become less sensitive for movements to the right, and you're still sensitive for movements to the left. You can manage with that, and many people again do quite well with 1 labyrinth. But if you lose 2 labyrinths, that's a disaster. Then you lose this high-speed sensitivity for head motions. And the other senses are not able to really replace that functionality. Well, let's go into those details. Here we see an example of a patient that lost peripheral vestibular function in a neuritis. So he or she sees the environment moving very fast and has the feeling as if the environment moves, or he moves in the opposite direction. And when we observe the eyes, we can see a nystagmus beating to the healthy side. There's vertigo, nystagmus and nausea and imbalance. The good thing is that central compensation takes care of that. This acute unilateral loss or fluctuating function, neuritis meniere, that is associated with vertigo, nausea and falling and imbalance, the classical leading symptoms for the diagnosis. But there is a tricky thing. If you have a slow vestibular loss, then there is no vertigo or nystagmus. Example is a vestibular schwannoma. So hearing goes slowly down, and people hardly notice that because it goes so gradually and slowly until the hearing loss reaches a level of 35 dB, the social level, and people notice that there's something wrong. They put a mobile phone on the right side and say, I can't hear very well. They put the mobile phone on the other side and they hear a clear voice and sound. So this tells them there's something wrong with my hearing. If you have a slow loss of vestibular function, you also don't notice it in the beginning. And because you don't see your labyrinths, and even many patients don't know that they have labyrinths, people don't make the association with all kinds of symptoms that they experience with a possible loss of a balance organ. If you go on the street and you ask people, how are your balance organs today, your labyrinths? Many people will say to you, what do you mean, balance organs, labyrinths? Never heard of that. Many people don't know that they have balance organs, so they cannot make automatically the idea that their poor balance can be caused by a vestibular problem. And even if they go to the GP, then generally the GP will say, you're getting older, it's normal to have a poor balance. Okay, what happens now in the most severe case you can imagine, acute bilateral vestibular loss? There were two very brave ENT doctors in Lund, Sweden. They did an experiment. This is the victim, Michael Kalbeck. He got injections of lidocaine to anesthetize the labyrinth, transtympanic. So here you can see the aggressor, his colleague and friend, Mans Magnussen. He did the injection first on the right side, and if you do it only on one side, you get the typical experience as if there is a neuritis, a sudden loss on one side. So you get the vertigo, the nausea and the imbalance. But here they did it also immediately after on the left side. And then, of course, we are very curious what is going to happen in this bilateral vestibular anesthesia. So Michael Kalbeck was laying on the bed, waiting and see what was going to happen. And slightly he started to feel more and more nausea. So he wanted to get out of the bed, to go to the toilet. And he noticed that he was out of control of his balance. But the striking thing was that he had no nystagmus and he had no sense of vertigo. Not at all, zero. Only upcoming nausea and imbalance and sweating. So he could come out of the bed and could stand, and he behaves basically like an old man, as you can see. He's suddenly 10, 20 years older. And the nausea increased and increased, and he walked very slowly, afraid to fall, like the nurses also, to walk in the direction of the toilet. And this is how he came back after 45 minutes of severe vomiting. So he avoided any head motion, as you can see, because that makes you more sick, like in motion sickness. Heavily sweating, but no vertigo, no nystagmus, zero. Only severe imbalance and nausea and sweating. So he climbed on the bed and hoped and prayed that everything would restore again. And he said to me, Herman, I've never been so sick in my life before. So hoping and praying that everything would become normal, but no vertigo and no nystagmus, as you can clearly see here. It took about 8 hours before everything was restored to normal. And they repeated that experiment 2 times. So it's reproducible, the findings, imbalance and nausea, but no vertigo and no nystagmus. So I'm very grateful to both doctors because they showed us something with a high clinical relevance. Number one is that in case of a bilateral vestibular loss, like in this acute situation, there is no vertigo, no nystagmus. There was severe imbalance and oscillopsia and an intolerance for head motions. And only in this situation, when it's acute, we see a severe neurovegetative symptoms. If there is aging, for example, and there is a slow loss, this severe neurovegetative symptoms doesn't occur. Okay, so how can we explain this? Well, vertigo and nystagmus only occur in case of acute asymmetries. But in case of a slow unilateral, like in a vesicular schwannoma, or in a slow, even acute bilateral loss, there is seldom or no vertigo or nystagmus. So this already points to the fact that vertigo is only one aspect of vestibular loss in a very specific condition, in case of acute asymmetries. For example, if you take Meniere disease, that is really the hybrid. So here we have a fluctuating function in the beginning, and that is associated with severe attacks of vertigos, because there is a acute asymmetries all the time, with the vertigo, nausea, nystagmus and vomiting. In time, because of the pathology in the ear, we see a decrease of hearing and a decrease of vestibular function. At the end, the number of attacks will go down because there is a destroyment of the labyrinth of the epithelia. So the attacks go away, but at the end the patient is left with a severe loss of hearing function and a severe loss of vestibular function, which is of course associated with completely other complaints than vertigo. And there is tinnitus. So this is very important to realize ourselves, that this is something that we have to memorize, that there are two aspects that are important in the management of patients with vestibular disorders. Number one, vertigo attacks with nausea and nystagmus. That's only about 30% of the patients with vestibular disorders, and we treat them maybe with vestibular sedatives, antiemetics, ablation in the severe cases. But the sensory function loss is something completely else, different. So that requires counseling, explanation to the patient what is going on and why he has certain complaints that I will go into in a moment. We can apply rehab, beta-stina, vestibular prosthesis like the balance belt and the vestibular implant. So that's the two things that are different from the traditional way of thinking. Now, how often does this happen, such a severe bilateral loss? Well, here you can see it's almost as common as a functional deaf patient. So about 0.3, 0.4%. And especially when people get older, so over 65, the prevalence is much higher than you would expect. Up to about 70 or 80% of the people have a hearing loss and a vestibular loss when they are over 70, 80 years old. Why do we miss it then? Why don't we see that so often? Well, because vertigo is much more prominent as a symptom, and the chronic aspects are often not recognized as vestibular. So for example, when people are aging, people talk about imbalance, that's a major complaint there, but imbalance can have many different causes. And that's why people say, okay, you get older, it's normal that your balance is impaired. So what is the major impact of this loss of sensory function, of vestibular loss? So what are these chronic symptoms? Then we need to go into the function of the labyrinth. Well, we realize ourselves that the vestibular system is a very old sensory system. There are many connections from the vestibular system in the brain, especially in the vestibulo-cerebellum or arche-cerebellum, the oldest part of the cerebellum. Many neurons, about 70% of the neurons in the cerebellum, receive vestibular input. After taste and smell, the vestibular system is the oldest sensory system. So all the other sensory systems are built up and help in synchrony with the vestibular system to detect motion and gravity, but they are developed later. So the system works in silence, the vestibular system. People don't know that they have a labyrinth, and you hardly are aware of that. It's completely automatized. Okay, now we look at the labyrinth and we see two parts. We see the vestibular organ and the hearing organ, so the vestibular labyrinth and the cochlea. Both are sensitive for motion. High frequency motion is sound, and low frequency motion are the head movements. So in terms of physics, they are very similar, and both systems use the hair cell that is typical, the mechanoreceptor, that transfers movement, displacement of the stereocilia, into electrical pulses in the nerves. How does that work, the hair cell as a mechanoreceptor? So we have two types of hair cells with a different kind of synapses and a different functionality. Now, if we look at the hair cell in detail, we know that the tips of the stereocilia that are increasing in length when they come closer to the kinocilium, the longest hair, then we see that they are interconnected with tip links. So that means that all the stereocilia and the kinocilium move in synchrony. Now, if that happens, if there is a movement, then we can see that on the tip of this kinocilium and stereocilia, there are connections, tip links, apart from the side links. So that makes sure that if there is a deflection, that the membrane opens and can close, leaving ions in and out. And by that, we see a change in the receptor potential, as you can see in the lower graph on the right side. When there is a deflection in the direction of the kinocilium, there's a strong change in this receptor potential because the canals open very widely. And in the other direction, they close, but that change is much less. So this is the basic reason for the hair cell direction sensitivity. In the neutral situation, as you can see here on the left, the receptor potential is 80 millivolts and the ion channels are almost closed. If you have a movement that deflects the stereocilia towards the kinocilium, then you can see that there is a wide opening of the ion channels and there is an increase of the number of spikes per second in the nerve. So they go from 100 spikes per second to 400 spikes per second. If they move in the opposite direction, so in a way that the ion channels close, then everything goes back to 0 spikes per second. Now you can see here that the increase from 100 spikes per second in the nerve fibers to 400 is much larger than the decrease down to 0. So this means that this hair cell is an asymmetric sensor. So by that, by putting hair cells in a different way in the labyrinth, you can detect in which direction the labyrinth is moving. So keep that in your memory as a basic background for the functioning of the labyrinth. Now, we have inside the vestibular labyrinth two parts. We have the maculae, the utriculus and saccule, and the canals. The oldest part of the vestibular system is the macula, utriculus and sacculus. In fact, they are a very rudimentary organ. And we see a similar organ, the statocyst, in the primitive labyrinth in lower animals, like we see it in sea cucumbers, jellyfish and lobsters. So basically, if you look here, it's a sphere, and on the bottom you see all kinds of hair cells that detect, movement. And on top of them are the calcium carbonate crystals, statoliths or statoconia, that move thanks to the inertia of mass and gravity. So this sphere is moving in the animal with the waves, and by that detects the motion and detects where gravity is. So it's a very fundamental detector of any movement, because it doesn't make a difference in which direction the system moves, all the hair cells will be stimulated in a specific way. To make that even more clear, you can think about this organ as a glass of water that is fully filled. So with every movement that you make, a translation, a rotation or a tilt will make the fluid move. And if there are hair cells in this system, they detect the fluid movement, or the otoconia movement on the top of the hair cells, as you can imagine, is the analogon. So this is a system in terms of physics that feels every motion, very precise and very sensitive. So in principle you have two of these maculae, two of these glasses in your head. With every movement you feel that there's something happening. But it's not specific. It cannot feel the difference between rotation, translation and tilt. The membrane is of course much more complicated in the human macula and utriculus than the glass of water. So you have the otoconia on top, and below there is a number of hair cells that are provided there to detect the motion of the upper membrane, the otoconia membrane. So again, with every movement, like in the glass of water, you can detect that something is happening. Now here the hair cells are oriented in different ways, so they can also detect different directions of head movements. These calcium carbonate crystals, they have an average size of only 10 micrometer. They are very hard. And there are many questions about how, this precise metabolism of these otoconia is organized. And we know that, for example, vitamin D plays an important role, and that by all kinds of factors, among which aging, there is a slow decrease of otoconia, degeneration of otoconia, presbyvasculopathy, already in this fundamental old organ. You can see that on the top, when you make an acceleration forwards and backwards, there's a deflection of the stereocilia. And also on the left down figure, you can see that when you tilt the head, there is also a deflection. And when you centrifuge people, then there's also a movement of the hair cells, the stereocilia. So in all cases, in D, the number in the hair cell indicated, you have a similar deflection. So you cannot feel any difference. Now to visualize it for you a little bit more clear, imagine that you are driving in a car and you put on the car, there's an antenna, old-fashioned car, and you put an orange on the top of the antenna. Okay, when you stand still, then the antenna is upright. Now if you start to move very fast forward, then of course the antenna will lag behind with the orange, and the inclination will indicate that you move forward. Now when you reach constant velocity, then there is no acceleration, and the antenna will move forward in a neutral position by the elasticity. And now with constant velocity you have the same feeling and observation as you do when you stand still. Forget about air friction. Okay, now I take off the antenna and I tilt it. And when I tilt it in this direction, there will be a similar deflection. And also when I centrifuge it like this, then the antenna will, with the orange, move outside. So these deflections are the same, so the brain gets the same signal and doesn't know whether this is caused by a translation, tilt, or rotation. So again, the system is very sensitive, but not very specific. And that is important because that means that we get all kinds of confusions. Now, all these hair cells and the otoconia are organized in a very specific way. In a simplification, you can see here in a 2D picture that in the utriculus, the direction sensitivity of the hair cells is directed towards an artificial line, the streola. So there is a preponderance of movement that induce a deflection and activation of the hair cells. Opposite to that, we have the sacculus that is oriented in a different way, and also the direction sensitivity of the hair cells is opposite. So they are directed away from this streola, as you can see here. Okay. Now, roughly spoken, the utriculus is in the horizontal plane, so sensitive for this kind of translations and tilts and centrifugations. And we have the sacculus that is more in the vertical plane, so in elevators and forward and backwards. And together they have a 3D sensitivity. In reality, these membranes are not flat, of course, they are curved. As you can see from very nice research from Professor Courtois from Sydney. And you can see that it is a three-dimensional structure, but a little bit more complex than in this two-dimensional representation. So the hair cells are distributed with some overlap in direction sensitivity. Now, what is the frequency dependence of this otolith or statolith system? It's important to know that because we know that all the sensory systems have a limited sensitivity for different frequencies. For example, hearing, you hear only tones between 20 Hz and 20 kHz roughly. If you look at the visual system, you have different frequencies of lights that you can see. That means different wavelength from 380 to about 780 nanometers, seeing blue and red, but you don't see infrared and you don't see ultraviolet. Vibration, there's also an optimum that is between 10 Hz and 400 Hz. What about the vestibular system, about this otolith system? Well, already in the 50s, Melville Jones and Groen calculated, based on the physics, what is this sensitivity? And that has been confirmed by all kinds of experiments. How does it look, more or less? This is precisely what you see. So there is low frequency at 0 Hz, where there is a perfect sensitivity. So when there is tilt, there's a constant deflection of the stereocilia. And when you start to move faster, slowly there is a decrease around 1-2 Hz. You see there's a steep decline of the sensitivity. So that is the optimal sensitivity, and that is based on the mechanics of the labyrinth. And there is also a lot of processing. We know that the hair cells also adapt to a mechanical, let's say, position, that if it remains constant, that the sensitivity goes down. But there are all kinds of other processes that also play a role. The information from the statolith membranes goes, of course, in the brain. And now comes an important signal processing. The brain tries to find out a difference between, for example, translations and tilt. And the effect of that is that in the lower frequencies, the sensitivity is going down. The reason for that is that imagine that I accelerate forward, constantly acceleration, and the deflection is there, then that is exactly the same as if I tilt my head backwards. So if I tilt my head backwards, it could be that I perceive that as a constant acceleration forwards. That can be pretty anxious and frightening. So to avoid that, the brain, getting information also from our other sensory systems, tries to reduce that sensitivity in this condition. But the effect is that, for example, when you are diving underwater and you don't see the surface, and you don't feel any different pressure in your feet and your head, that the labyrinth cannot tell you during the slow movements underwater where is gravity. The sensitivity for low frequencies is reduced for gravity factor. By that you have no idea, a diver underwater, what is up and down. And you can only find it out by making bubbles and look with a lamp how the bubbles go and know that the surface is there. So there is some side effects here. That's one of the biggest issues in the vestibular system, how to feel motion in the right way. Translations, rotations, constant accelerations, etc. Now if you look at this membrane, you can see that the otoconia distribution is much thicker. There are more otoconia in the extrastriola than above the striola. That means that if you give loud sounds that give a high frequency, that stimulates this striola, but not so much the heavy, slow membrane around it. So you have a part in the utriculus and saccule that are more sensitive for higher frequencies, because the hair cells can feel it, only the mechanics is too slow. And that is to some extent comparable to what is happening in the retina of the eye. There we have the fovea in the middle with 1 degree, where you have a very densely packed cones that detect details of vision. And then around it is the peripheral retina, where there are rods, more rods than cones, and you don't see much color, but you see predominantly movement. So there is a different functionality You have a very high resolution in the fovea and much less in the rods. Now, you can compare that to some extent with happening in the membrane of the utriculus and sacculus, this fundamental membrane, that in the middle you feel very fast changes, jerks of movements, and around it it's more sensitive for low frequency, gravity, etc. So what we call a sustained system in the extrastriolar and a dynamic system, a transient system in the middle of the utriculus. So it's a complex structure. So this sustained system is very much dependent on the mechanics of the labyrinth. And the labyrinth, the membrane is very slow. Whereas in the transient system, you can stimulate it very directly with high frequencies like in vestibular evoked myogenic potentials, and you stimulate specific this middle area, the striolar hair cells. Now you have these two systems on both sides, and they detect very precisely almost every tilt and translation, as long as they are dynamic. You need activity. And the striolar hair cells in the middle maybe play a role in the jerks and very fast warnings you're moving, and in the past they were used for hearing, because the old otolith and the fundamental parts, the utriculus and sacculus, in the macula were in the past hearing organs. We see that also in the development towards a more refined vestibular labyrinth. As I told you, the otolith and utriculus and sacculus can also detect sounds, also a movement. And especially in lower animals, in frogs, they hear with their sacculus. They don't have a specific organ like a cochlea. They have another kind of intermediate. But in the development of the whole hearing system, we see that in the higher animals there is the development of the cochlea focusing on high frequency motion sound. And parallel to that, you see the development of the semicircular canals that are designed to only detect rotations. So by this, suddenly the brain can much easier more detect the difference between translation and rotations, because we have one organ, the canals, that detect the rotations. They work like this. We have the cupula, and inside the cupula we have the hair cells that are all oriented in the same way. So the direction sensitivity of the hair cells in one cupula is all pointing in the same direction. So by that, the cupula becomes a direction sensitive membrane. As soon as you start to rotate, the endolymph in the canal will lag behind and will push against the cupula. That is what you see here when you have a clockwise acceleration, rotation. There's a very fast deflection of the cupula within 2 milliseconds with a maximum deviation of 1 degree, and the hair cells are stimulated. So immediately they detect the rotation. It's a very fast system. Now, if you keep on rotating all the time, then there is no acceleration anymore. So that means that there is, when you remember the law of F is m times a, Newton's law, that there is no force anymore because the acceleration is zero. So then slowly the cupula, by the elasticity, will restore its original position. Now this small tiny cupula has to push against the fluid, and that takes about 20 seconds. So then what happens is that at the end the cupula stands back, and if you suddenly start to stop after a rotation, you get the opposite reaction. So here you stop while you are rotating, the fluid will come from the other side and push against the cupula and deflect the hair cells, and you get a post-rotatory sensation, a post-rotatory nystagmus. And then ultimately the cupula returns back in the neutral position, and then you don't feel any motion anymore, you stand still. So if I try to visualize that for you, what is happening when I start a rotation? So this is my cupula. I start to rotate to the right. What happens is, due to the inertia of mass, my cupula will move in the opposite direction, telling me that I rotate. Now during my constant rotation there is no acceleration and my cupula goes back to the neutral position by the elasticity. So while I'm rotating there is no sensation of rotation for my labyrinth anymore. So what is happening now when I suddenly stop? I stop and my cupula moves in the opposite direction because of the inertia mass and indicates that I'm rotating to the left side. That is the post-rotatory nystagmus. And then I'm not really rotating, I'm standing still. And then the cupula goes to the neutral position by elasticity again and indicates you're standing still. So the labyrinth, the canals, are very good sensors for changes of velocity, but not very good for constant velocities. They are dynamic sensors. Canals sense rotational acceleration, but no constant rotations. So they are only sensitive also for rotations and not for gravity. And that is because the density, the specific density, mass density of the endolymph is exactly the same as that of the cupula. That is what you observe when you slowly rotate a canal. Then the cupula is not changed in position due to gravity. On the left and the right side, the position of the cupula in the ampulla is exactly the same. Now this changes when there is a problem in the labyrinth. So if calcium carbonate crystals come in the canal, as you can see here, then this movement of clots, they can induce a flow of the endolymph and a deflection of the ampulla of the cupula. So it can also be that the calcium carbonate crystals from the utriculus came on the cupula, make the cupula more heavy than the endolymph, and by that also the canal becomes a sensor of gravity as well, and that messes up everything. So not only you have the BPPV, but you also have the problem that the labyrinth in itself is not working properly. To some extent the brain can learn to deal with that as long as the contribution of, for example, this otoconia in the canal is very small. If you drink alcohol, you have the same kind of experience. You also get a postural nystagmus that is induced by the alcohol coming from the blood flow into the cupula. Alcohol is lighter than endolymph, so it makes the cupula lighter and the cupula starts to float. By that there is a deflection of the hair cells and you get a stimulation, as you can see, of the system. So now if you rotate from one side, laying on the right side, laying on the left side, you will observe a post-alcoholic nystagmus type 1. In time, slowly the alcohol will migrate from the cupula into the endolymph. So at a certain moment it will be matched and then there is no effect anymore. But after a while, all the alcohol will be in the endolymph and not in the cupula anymore. So the cupula becomes relatively heavy. So you get the opposite posture-dependent nystagmus, post-alcoholic nystagmus type 2. In time it will disappear and the effect will be smaller. So alcohol changes the density of the cupula and has a similar effect as with BPPV. Now the canals sense rotational acceleration, but normally no linear acceleration or gravity. That is a healthy labyrinth. It should be like that. What is the frequency dependence of the canals? Here we can do the same kind of calculation and calculate the sensitivity. Now if you look at the right upper part of this video, you see that when the canal is moving very slow, there's hardly any reflection of deflection of the cupula. With increasing velocity, you see there's more deflection of the cupula. And that is what you also see in the graph. There's first, with increasing frequency, a higher sensitivity. But there's a limit at a certain moment when you move too fast. So you have a very fast frequency like here, then there is hardly any, again, deflection of the cupula. So there is a decay of the sensitivity. The optimal sensitivity, because of the mechanics of this canal, is between about 0.2 Hz and about 10-15 Hz. And that is associated with different functionalities and also with different tests. The caloric test is what we call a low frequency test. The rotation chair is a medium frequency test, and the head impulse tests are high frequency tests. And it can be that you have a normal calorics and an abnormal head impulse test, or the other way around. So these are complementary tests in the diagnostic tools that we use in vestibular testing. Now, apart from this system that is determined by the mechanics of the canals and the utricles and saccales, there's also, of course, a brain system that helps to optimize functionality. There is a problem with the canals. They are not so sensitive for low frequencies. And to create that, there is what we call the velocity storage memory. So what happens is that if you start to stimulate the labyrinth, then this activity is stored in the brain, in the nucleus, prepositus, hypoglossy and the cerebellum. And by that, even if there is no stimulus for the labyrinth, there is still this knowledge in the memory which helps you to feel rotations that have been in the past. So when I make this example of rotation, so I start to rotate, I adapt, and I suddenly stop, what happens is that, okay, the mechanics has stopped. Within 20 seconds, I don't feel any rotation, but the memory in the brain takes care that I memorize the rotation much longer, about 60 seconds. And that makes the canal system more sensitive for low frequencies, as you can see here. So a lot of signal processing of the signals of the utriculus and saccales and the canals, as we have seen now. Now, according to first law of Ewald, the cupula is maximum deflected when you rotate around an axis that is orthogonal to the plane of the canal, and not so much when you rotate around an angle, an axis in the plane of the canal. So for 3 dimensions, you really need 3 canals, and that is what you see here. And when you rotate to the right and to the left, you stimulate the different canals. Now, they are oriented in this way. So you have the horizontal canals, like this, a little bit tilted, and they are complementary. So if I look at the activity in the vestibular nuclei, I can see that when I'm standing still, there is activity on the right side, on the left side. When I rotate to the right side, I get a huge increase there and a small decrease there. When I rotate to the left canal is much more sensitive for movements to the left, I get a huge increase there and a small decrease there. But thanks to the fact that the brain looks at the difference, everything is symmetric. As soon as I lose one labyrinth, I get a fundamental asymmetry. So when I lose my left labyrinth, when I rotate to the right side, there's a huge increase of the spontaneous activity. Nothing is happening here because it's dead. When I rotate to the left side, there's a small decrease there and nothing is happening there. So the sensitivity is much bigger to the right than to the left. And that is for slow movements, it's almost symmetric because then you are within the small range of sensitivity. But when you move very fast, there is a huge difference. Now, for the anterior canal and posterior canal, it's the same. So when I rotate towards the anterior canal, I get an excitation and an inhibition in the posterior canal. When I move backwards in the direction of the posterior canal, I get an excitation here, increase of activity, and a decrease on the other side, and also for the other pair. So in 3 dimensions, you have this push-pull organization that makes it possible, thanks to the activity of both labyrinths, to have a symmetric response on central level. Now, this information from canals and the utriculus and saccales provide you with a sensor that is very fast and can detect any motion. And you have it on both sides. And thanks to the fact that you have 2 labyrinths, you have a wide range of sensitivities. Now, if you put those canals and otoliths together in terms of frequency dependence, this is more or less how it is. So it's optimal between about 0.1 and 10 Hz or a little bit higher. And the relative sensitivity is, of course, something that has to do also with how the brain is processing this information. And that is within the context and learning and training, and also using additional information for the other senses. Now in time, the number of hair cells decline with age. So we have presbyvestibularity, and that is all over the canal and in the utricle and saccus. Nothing different from hearing. So there is presbyvestibularity like presbyacusis. And especially we see that with age there are more and more falls and even people that die because of that. So it's a serious problem, falls, and calculations by Dan Merfeld and colleagues based on threshold measurements shows us that bilateral vestibular loss is not rare, and it might even account for up to 50% of the age effect of balance. Now that is crucial because it means that if you have an older patient with an impaired balance, that can very well be that there is a dominant factor of reduction of vestibular function. And now with the emerging of the prosthesis of the vestibular system, like the balance belt and the vestibular implant, there are therapeutical options. So here you can see how the canals and the utriculus work together within the frequency domain of vision and somatosenses. You see the canals and the otolith system are relatively fast detectors, where vision and somatosenses are slow, low frequency systems. So this already indicates that vision and somatosenses cannot replace canal and otolith function. Also, because the otolith can detect everything, every motion, you can say that even if you lose your canals, there is still a sensitivity for rotation, translation and tilts. So just a very bad response on a head impulse test doesn't say that the otolith system cannot replace to some extent the function. So in summary, the vestibular labyrinth is the most sensitive and fastest sensor of head motion and dynamic head tilt. And basically it adds speed to your life. Like you saw a little bit from the experiment with the lidocaine, that Michael Kohlberg was suddenly moving very slowly like an old man. Now, the information from the labyrinth goes, of course, into the brain. And you can say that there are two major areas that are major projections. You can see that the anterior horizontal canal and the utriculus, they send their information via the superior nerve into the vestibular nerve into the brainstem. And you can see that the posterior canals, together with the succulus, take the branch of the inferior vestibular nerve, collect together with the vestibular nerve and go into the brain. 5% of the fibers are efferent fibers, and we know now that these efferent fibers play a role in the sensitivity regulation of hair cells peripheral. So what is central and what is peripheral? Okay, now the information from canals, utriculus and succulus go to the vestibular nuclei, and then it is distributed in different directions. You can see that the medial and superior vestibular nuclei, they receive information predominantly from the canals, and via the oculomotor nuclei they take care of eye movements. You see that the canals and the utriculus and succulus project to the vestibular nuclei, the lateral, inferior, medial part, and they play a role in vestibulospinal reflexes and head stabilization. Information also goes from the utriculus and succulus to the archicerebellum, the cerebellum, so there's a direct projection there, and the cerebellum plays an important role in adaptation of all these reflexes and controls. Now first, let's go on the level of the vestibular nuclei, how this information is used. First, the vestibulo-ocular reflex, predominantly from information from the superior vestibular nucleus. So we see that the labyrinth projects via this vestibular nucleus to the oculomotor nucleus, controlling the extraocular muscles. Extremely fast reflex, a latency of only 8 milliseconds. This is the fastest motor reflex in your body. If you shake your head, then you can still see on the screen everything very sharp. There's no problem. And that is thanks to this vestibulo-ocular reflex. When you move your head to the left, your eyes move to the right. And that's why you stabilize the image. When you look at a target in front of you, for example your finger or something else, and you move slowly, you can follow it. But when you move too fast, then you get a blurred vision. And that is because then you follow the cortical pathway that you can see in the graph here, that the information goes from the retina via the thalamus to the visual cortex, to the midbrain, the pons and the cerebellum, and then reach the vessel nuclei, oculomotor nuclei, and to the extraocular muscles. That is a pathway, the cortical pathway, that takes about 75 milliseconds of latency, 10 times slower than the vestibular reflex. Again, this shows you that there's no way that the visual eye movement, smooth pursuit, can replace the vestibular system. It's fast and too fast for the visual system. So when you move your head, you get this image stabilization in 3D, thanks to the canals and the utriculus and saccule. So you have this direct pathway, 8 milliseconds, but now there is a fundamental problem. Imagine that I make a fast movement. So I look straight forward. I want to keep on looking straight forward while I move my head. Now if I move my head very fast to the left, I do it slowly. So what happens is during the movement I activate my labyrinths. They take care of the shift of gaze so that I can keep on looking in the same direction, stabilization. But at the end of the movement, there is no stimulation of the labyrinth anymore, and my eyes will normally shift back to the neutral position because there's no activation of the muscles. How can I prevent that? Now, that's why we have two memories in the brain. For the vertical eye movement, the interstitial nucleus of Cajal plus the cerebellum. And for the horizontal eye movements, we have the nucleus praepostus hypoglossy and the cerebellum. Now forget about the names, that's not so important. But what happens when you stimulate your labyrinth by moving your head to the left very fast normally, then the information goes via the direct pathway to control the eye muscles, but parallel, the activation is stored in the memory. So that even if I stop, there is still activation in the brain, and that takes over the control of the eye muscles so that I still stabilize it. And that memory holds the gaze for about 100 milliseconds. And that means that the visual system can take over. It's fast enough to do that. So what happens? I move my head, I stabilize the image because of the direct pathway. Now my visual system takes over thanks to the fact that my gaze is maintained for 100 milliseconds by the memories. If you lose those memories, you get a problem. And that is that you cannot, with these integrators, keep on holding gaze. And that's also what you see when you ask a person to look to the right, then he cannot hold that gaze because the memories are away and they shift back to the neutral position. You need to correct every time when you look sideways, so you get a nystagmus to the right. When I look to the left, the same thing happens, but I get a nystagmus to the left because it's about the memory. That memory is, as you saw, in the brain, and it uses information from the nucleus of Cajal and the praepostus hypoglossy, etc. So gaze-evoked nystagmus is a central disorder. And that's something that you never see in peripheral disorders. When we look at nystagmus, that is a very specific phenomenon. The nystagmus is composed of a fast phase and a slow phase in horizontal, vertical or torsional, rotational direction. The fast phase is only a reset. The slow phase is the real physiological response. Here you can see an example and make a simulation. So the eye is following targets circling around. And the slow phase, as you can see, is following the target. And then the eye is reset to be able to follow the next target. Optokinetic nystagmus, very physiological. The reason why there is a reset is simply because the eye cannot rotate for 360 degrees. So the reset is just a reset, and during the reset you don't see anything during the visual, there's visual suppression during the fast phase. You only see during the rotation, and that's why you have a constant rotation during the slow phase perception of the movement. Okay, now we can have this rotation also by stimulating the labyrinth, as you can see here. So there's no vision, it's closed, the goggles. So you get a pure horizontal movement, horizontal nystagmus. And that is what you can see also on the graph on the left side. And if you take out the fast phases and you only calculate the eye velocity, you can see that the eye velocity is opposite to the head velocity. And that's perfect, what you want, image stabilization. Now here you can see when you make a horizontal movement, when it's slow, you get a smooth eye movement in the dark. And when I move a little bit faster, I get a horizontal nystagmus, rotating to the right, right beating nystagmus, rotating to the left, left beating nystagmus. So that's why you see this horizontal nystagmus. But also in the vertical plane, when I move slowly up and down, I get a smooth eye movement. But when I move faster, then I get an upbeat and a downbeat nystagmus. In the dark, completely physiological. So because I stimulate the vertical canals here. So upbeat and downbeat nystagmus. But there's a third dimension. So when I make lateral flexion like this, then the eyes start to counter-roll. So you have again a smooth movement and a fast reset. And this ocular counter-rolling is thanks to the fact that you stimulate the labyrinth by this lateral flexion. Again, direction of the fast phase. That is how you name the nystagmus. And the real physiological phase that you should calculate how strong is it is the slow phase. Here you can see the scheme that was designed and experimental verified by Florence, famous physiologist in pigeons, but it holds also for humans. It shows you that if you stimulate the right posterior canal, the RPC, that you get an upbeat and a right rotatory nystagmus. Right rotatory means that the upper pole of the eye is rotating towards the right ear. When you stimulate the left posterior canal, you get an upbeat nystagmus and a left rotatory, so left rotatory upper pole beating towards the left ear. And that's the typical nystagmus when you stimulate the left posterior canal. Same holds for the right anterior canal and left anterior canal. You get this typical rotation vertical pattern. And as you can see clearly, there is no pure rotatory or pure vertical nystagmus that you can create by a peripheral stimulation. So it can be if you make a strange combination of lesions, for example, but normally when you see a pure rotatory or pure vertical nystagmus, it means that there is a central pathology. Okay, now we move to the influence of the cerebellum. Information from the inferior vestibular nuclei go to the cerebellum. And this is used as an adaptive control center. It receives, for example, visual information from the parietal temporal visual area, the inferior olive, via the flocculus, and then via the Purkinje fibers, so inhibitive fibers, controlling the activity on the level of the vestibular nucleus. So by that you can optimize via visual feedback the reflexes of the vestibular system to vestibulospinal and can be vestibulo-ocular reflex and perception. So it means also that that the vestibular system is controlled very strongly by an adaptive control of the cerebellum. We call that as the vestibular adaptive control center. If you close your eyes and you measure the nystagmus, for example, goggles, and prevent vision, you get this vestibulo-ocular reflex. But when you do that, when you still have the possibility to use vision, visual suppression, then via this flocculus and the cerebellum, you can suppress the vestibulo-ocular reflex. So that shows you how adaptive the vestibular system is, thanks to information also from other senses. Okay, then we have eye and head coordination in the neck. So here you can see a bird without eye muscles. So he needs simply to look all over the place by rotating the head, because there are no eye muscles, there's no eye movement. In birds, we see also other type of movements. Here there is lateral vision. One eye is on the right side and one eye is on the left side. And by that, instead of controlling the eyes to stabilize gaze, he stabilized the head to stabilize gaze. And pretty well, as you can see here. Okay. Now imagine that you are a pigeon. So I have vision on the right and on the left side. My right eye looks at the right, my left eye to the left. Problem now is that when I'm moving, I need to move my eye for stabilization on the right side to the right and my left eye to the left. That is a divergent eye movement, which is not controlled by the vestibular system. So instead of that, the pigeon uses head stabilization. He stabilizes his head, then he walks with his body below his head. So in this position, he moves forward, keeping the head stable in space. And then because he wants to move forward, he moves very fast his head forward, the head nystagmus. So by that, you get this rhythmic movement of the head, which is a typical example of head stabilization instead of gaze stabilization by the eyes. You can see that the pigeon is walking, have this fast head movement, and when you replay that in slow motion, you see how he stabilized the head in space while moving with the body forward. Perfect head stabilization, which is an alternative for the nystagmus that we see. Humans also have this head stabilization. It stabilizes our head in about plus or minus 3 degrees around this axis, for example, when you're walking like this. So when you're walking, you stabilize images by the combination of head stabilization and eye stabilization. What about the vestibulospinal reflex via the lateral vestibular nucleus? So there are a lot of pathways that make sure that there are very fast correction upon your posture and balance. Let's have a look. The vestibular impact on postural control. What is very specific? Well, it regulates the muscle tone relative to gravity, that you have a certain stiffness, the extensor muscles. And it regulates your center of mass over your base of support, that you do not fall, that you are in balance. Now there are many structures controlling balance: the frontal cortex, the cerebellum, the basal ganglia, brainstem, spinal cord. What is the specific contribution of the labyrinth? Speed. Again, speed. Fast detection and correction of imbalance. That means that if you lose that information, you are impaired regarding to balance control. Show that in a moment. Of course, the information from the labyrinth not only goes to the brainstem, but also goes via the thalamus to the cortex. And it reaches the parieto-insular vestibular cortex, the PIVC, which is considered as the vestibular area. But there are much more areas in the cortex that receive vestibular information for all kinds of purposes. Now, what is the major impact of chronic vestibular loss, sensory function loss? So, then we have this scheme. The labyrinths work together with all kinds of other sensory systems, gravitroreceptors in the body, somatosensory information, vision and hearing, to achieve many targets, functions. One of them is circadian rhythm. There's a projection from the vestibular system to the suprachiasmatic nucleus that is your biological clock. Together with day and light, the labyrinth, by detecting movement, it programs your biorhythm, your biological clock. Nowadays we all wear these watches to indicate how active you are. Well, this activity sensor is also your labyrinth, programming your biological clock. On top of that, we know that a part of the blood pressure regulation, especially to the brain, is controlled by the vestibular system. Here you can see a publication already many years ago. It was discovered already in 1964 from space research, that the vestibular system has an important role in controlling blood pressure upon postural transitions. For example, when you come up, then of course when you do that fast, there's a tendency of the blood flow decreasing because because of gravity factors, to the brain. Now, of course, there are blood pressure sensors that help to detect that, and then via the reflex can control blood flow and increase that. But then you have to first have the loss of blood flow before you detect it. So that's slow. The labyrinths provide already anticipation on that by directly detecting that, start to change the blood flow in the brain to increase that, and then the blood pressure receptors take over. So the fast part of the blood regulation in the brain is vestibular. And that means also that in bilateral vestibular loss, the cardiovascular reflex is impaired and often can lead to orthostatic dizziness, in contrast what people were advocating in the past. Now we have spatial orientation. There are many factors that affect spatial orientation, and one of them is severe bilateral vestibular loss. We see that there is a degeneration of head place and head direction cells in the hippocampus, a loss of navigation. What does that mean? Well, it means that, your memory for navigation is impaired. So if I tell you at a certain moment that the toilet is somewhere below and you find it one time, then the next time in a healthy person you find that very fast again. But when a patient has a bilateral vestibular loss, this memory of navigation is lost. So it means that it will be much more difficult to re-find locations again and again. One of the major impacts, of course, of vestibular loss is balance control. And we see here in patients with severe bilateral vestibular loss that the number one complaint is imbalance, not vertigo. So imbalance is an important thing. Here you can see a boy who lost his labyrinth 1 year ago by gentamicin intoxication on both sides. And you see that he still has a wobbling head, and especially on the sand where somatosensis is impaired, he really walks like a drunken sailor, but he only drank Coca-Cola. So this will never become completely normal. He will always be handicapped in balance control. But still, with rehab, intensive training, he can improve. Another aspect that you have to realize here is this lady who lost her labyrinths also 4 years ago, had a lot of training, but is so afraid of the sensations that she had. So when she moves in total, she wants to keep her head stable on the trunk to be sure that nothing bad happens. And she really becomes so in control, try to be so much in control that she is very, let's say, obsessed by this problem in the vestibular system and in balance. You can imagine that. So she's very afraid to fall. And you see that in many of these patients with vestibular disorders, there is a comorbidity of all kinds of issues, fear, anxiety, fatigue, etc. Psychological factors play an important role. Also in how you can deal with vestibular disorders. So it's a circle. Now, image stabilization is crucial. And we use that all the time when we walk. And you can check that with the very famous head impulse test, which is now common practice in ENT and neurological consultations. So you make a very fast head movement, and in a normal person, the person can keep on looking at you, as you can see here. And in detail, the patient is asked to look at your nose, and while you move the head very fast, you can see that her eyes keep on looking at your nose. There's no correction of the eyes. However, when you do that in a patient that lost his right labyrinth, you can see here that when you move to the left, everything is perfect. But when you move to the right, as you can see here, then there is a correction. So he's always too late. So he loses speed. Of course, the labyrinth is affected. So you can use a mobile phone to measure that, to observe that. You put the mobile phone preferably in slow motion, and then as you can see on the lower video on the right lower part, when you play it in slow motion, you can perfectly see all eye movements during the brief fast head movements. So you have no problems in identifying whether it's normal or not. Here everything is normal. So when you look at with a mobile phone to this patient, you can see that when I move the head, there is a clear correction. she's always too late. And it doesn't matter when I move to the right or to the left, it's always impaired. So she has a very bad image stabilization. And when she walks on the street, then she recognized this problem. She says, I have impaired visual acuity. Everything is moving. I cannot read signs. I cannot recognize faces. It's called oscillopsia. And these patients are often sent to the ophthalmologist, and he finds, of course, that everything is completely normal. There is no problem in the visual system. So when you start to test these patients by putting them, for example, on a treadmill, then you can measure visual acuity without and with movement. First you do it when they stand still, that is your static visual acuity, and then you start to measure the dynamic visual acuity at different speeds, 2, 4 and 6 kilometers per hour. Now what you see then, if you calculate that in healthy people, the open circles, there is at the different speeds 2, 4 and 6 kilometers per hour hardly any change in visual acuity as compared to static visual acuity. For the closed circles, these are patients with a modest to severe bilateral vascular loss, you see that already at 2 kilometers per hour they lose about 0.3 in visual acuity. And when they move faster, if they can, then you see that the visual acuity even goes worse. So this is really a substantial loss of visual acuity. So the vestibular labyrinth is the most sensitive and fastest sensor of hand motion and dynamic tilt and adds speed to your life. If you lose them, you reduced dynamic visual acuity. You have a hypersensitivity for strong visual stimuli, disoriented after fast ipsilateral head movements, you have a reduced balance and increased fall risk. You have to slow down everything and pay attention always. Fatigue. You feel 20 years older. So here you see the list of symptoms. The acute loss or motion sickness, you have nausea and vomiting. In case of acute asymmetries, you also have the vertigo and the nystagmus, the nausea and the vomiting. When there is a gradual loss, there's no vertigo and no nystagmus. If you lose vestibular function, no matter how that happens, you get all kinds of problems with image stabilization, with balance, automatization of many things. You get tired, you become visual dependent, and you try to avoid all these situations. So social isolation is a common problem. Reduced navigation skills and even a disturbed circadian rhythm. So many issues are playing a role here. How strong is the impact? Of course, it depends on how much you lose. What frequency range of loss? Is it low, high, middle frequencies? Is it chronic or fluctuating? Do you have attacks as well? Is it unilateral or bilateral? Are the canals and or the maculae involved? What is the condition of your other senses? What are your motor abilities? What is your profession or hobbies or other activities? And what are your coping mechanisms? So what are the take-home messages? Number one, the labyrinth adds speed to your life. You can live without it, but then you have to slow down with everything. Two aspects require a very different management in vestibular disorders. You have the sensory function loss, that's about 70% of the vestibular disorders, and it has a permanent impact on many things. And then you have the acute asymmetries that induces vertigo attacks, nausea and nystagmus in about 30% of the vestibular disorders. Thank you very much for your attention.